if you look at management of care on NCLEX, and the topics that I'm going to be doing in 212 pretty much for the rest of the semester, what you will see is that it will comprise anywhere from 17 to 23% for management of care, and safety and infection control is 9 to 15%. So if you, when you take your 75 questions, you can have 25 of those questions in those two categories, because it's an extremely high percentage of the questions for NCLEX. Just as an FYI, where I got this information, in your spare time if you want to look at it, is on the National Council of State Boards of Nursing, ncsbn.org. And if you go on to NCLEX exam, they have the test plan on there. Okay, so let's look at some of those things in these two categories, and this will explain why these next two management units are such a mishmash of stuff. Okay, basically look at safe and effective environment, advocacy, I'm going to cover, assignment, delegation, supervision, I'm going to cover. It's extremely important. Case management, collaboration with the interdisciplinary team, concepts of management, establishing priorities, ethical practice, information technology, performance improvement, referrals. Some of the other things, if you look, are reporting incidents, irregular occurrence of variances, safe use of equipment, precautions, restraints, those types of things. But what I'm going to tell you is this is going to be a very large percentage of your test. Let's see if I can get that. If you look on your National Council of State Boards of Nursing, like I said, NCSBN.org. If you go to NCLEX examinations, you can see over here where it says test plans. Okay, if you click there, you can see that there is a test NCLEX RN. Make sure you get the RN, not the PN, okay? See, here is also a detailed test plan. Now, you will see that there's also a detailed test plan for educators. Really, there's no difference between the two test plans. They don't tell us what questions are going to be on it. The only thing that's on there that's different for the educators is how to write the questions. Okay? You can print that one out if you want to, but if you look at the detailed test plan, it breaks it down even further. And one of the things that I would give you a little clue is that whenever you are studying for NCLEX, I would print out this detailed test plan, because if you look, this is the stuff that we just went over, but if you look at the detailed test plan, you can see there are different bullet points. And I would make sure I knew something about each one of those bullet points, and if I was unfamiliar with that topic, then I would do a little bit of research. Okay? One of the things you'll see is that all of these are included in your curriculum, but some of them you may be a little less familiar with than others. Especially that stuff you got in the first semester. Okay, questions about that? Alright, so let's start with this management improving quality. Now, on evidence-based practice in the concept book and the med-surg book as well. I'd take a look at those. Basically, when you're talking about management systems, when it's talking about safety, not only safety for the client, but safety for your employees, safety for the community, most people use what we call a total quality management philosophy. This is like an overall philosophy. What we see is that organizations have a commitment to excellence, and it's more of a customer-client focus, okay? That doesn't mean only the consumers of your product, whether it be healthcare or chicken sandwiches at Chick-fil-A, okay? There can be external and internal customers. Your internal customers are your employees or the departments or whomever has contact. Your external customers or clients are your consumers of your product, whatever that product may be. Basically, when you're talking about total quality management, you're talking about total organizational involvement. That means that anyone from the CEO down to the guy that sweeps the parking lots should be involved in quality management for that organization. Basically, what you're going to see is that there may be quality tools and statistics for management. How many of you work as CNAs in an organization? Okay. Do you guys do any type of audits? What types of audits do you do? Patient satisfaction, hand washing, what else? Signing for hourly rounds. You ever check the refrigerator for the temperature? Okay. Though now a lot of refrigerators are so automated that they report back to a central station, and you get a report that if it's out of whack, you don't actually have to do the temperature check anymore. But those are some of the audit type things that you're going to see. One of the things with total quality management, they identify key processes for improvement. What are some of the things that we would want to see that are improved in a hospital system?
Patient care.
Patient care, okay? Quality of a clinical type issue, okay? Because that's one of the things that you would want to do. What else?
Decreased infections.
Decreased infections, again, that can be sort of considered a clinical focus, or it can be a systems focus, okay? Because one of the things that hospitals do is they have an infection control department. Why would I want to centralize my audits for infection control? Why is it more effective? I'm sorry, Jeff?
A larger cumulative of knowledge.
Very good. You get larger data, okay? You get larger data. That's why we report infections and outbreaks to the CDC. Because they are able to figure out, you know, if you go on the CDC website during flu season, you'll be able to see where flu is and where it's considered endemic or an epidemic. Basically, one of the things that you want to do is if you travel to one of those areas, you stand with your hands like this and make sure you've had your flu shot. Okay? One of the things with infection control in a specific hospital is that they can see, are they having a problem on just one unit? Or are they having problems on multiple units? One of the things that infection control found out in a hospital that I read about is that they were having increased levels of MRSA all throughout the hospital. And what they found is that the gloves that the hospital was buying, because they were cheaper, were defective. And so even though the nursing staff and the hospital staff were gowning and gloving appropriately, the gloves were defective and they were contaminating their uniforms because of that. Okay? So, and they probably never would have found that if they had just been a unit-based system, because you couldn't see that it's a system-wide problem versus just a specific unit. One of the reasons that we no longer are allowed to wear those fake nails, acrylic nails in the hospital, is for that reason. They found that nurses in the NICU that wore those nails basically contributed to high rates of infection in those neonates. So that's one of the things that happened several years ago to make sure that we reduce the risk of infections throughout the hospital. Now, along with total quality management, there is a system called continuous quality improvement. Whereas TQM is the umbrella term, CQI is more of a tool to help us improve quality and performance. Basically, what you want to see is that it's the process of that systematic evaluation to improve not only patient care, but employee performance. Basically, some of the components are like comprehensive quality management plans. And one of the things that you see that has come out of this continuous quality improvement is clinical paths. Alright, so when patients are admitted to the hospital, they are put on a specific clinical path. For example, patients that come in with a myocardial infarction or an MI. Basically, what you're going to see is that within that first 90 minutes, these things will occur. Within that first day, these things will occur. Within that second or third day, these things will occur, and hopefully by the end of that third day or fourth day, this patient's discharged. One of the things you will see with clinical paths is that as a nurse, you are responsible for documenting that these patients have achieved those indicators. And if they have not, why? Those are called variances. And all variances need to be documented in some way. What do you think would be the most common reason that someone would have a variance? Say, for example, you've got a patient that comes in that delivers a baby. Typically what you're going to see is that they have to stay in the hospital for 24 hours, but they can stay up to 48. What would be one of the reasons that they might have a variance? Complications such as what?
C-sections instead of
C-sections instead of
a
a vaginal birth.
multiple babies.
Multiple babies. Prematurity for the infant. Diabetic moms. Okay, those are all reasons that you would have variances. And they need to be documented so that insurance as well as the hospital is covered. Anytime you have someone on a specific clinical path, and there's probably going to be very few patients that are not on a clinical path, you need to document that they've met those indicators or they did not meet that indicator within that time frame and why. What you're going to see with this CQI is that the resource group, coordinators, team leaders, and the team. Nurses basically are part of the team. Now, if you have a CQI committee on your unit, you may be the team leader. And a lot of times what you will see is that as part of shared governance, which we will also talk about, nurses are taking the role of team leader on their unit for their quality improvement to make sure that those indicators are looked at, audited, and the results from that are communicated to the rest of the staff and the team. Okay? Other things that you will see that are components of the CQI is that they have to have a standard. What kind of standards would you imagine that you would want? Say, for example, for charting. Yeah, that the documentation was completed in a certain amount of time. Those of you that have assisted with admission assessments, when does the plan of care have to be on that chart? Any idea? Well, not necessarily right when they get there. The physician's orders probably need to be, okay? But the nursing plan of care needs to be on there within 12 to 24 hours, depending on what your philosophy of your hospital is. One of the things that you'll find is that there is a time limit on when the admission assessment has to be done. There's a time limit on when does that nursing plan of care need to be there. And if it's not, you need to figure out what that variance is due to. Is it a problem with the system? For example, if this patient comes in for outpatient surgery or inpatient surgery, but what happens is that they're admitted to the hospital for your surgery, they have the surgery, and then after surgery they sleep for 24 hours? How can you get your admission assessment done before the 24-hour mark? What's the best way to complete that? Where would the admission assessment need to be done? In pre-op, right? Okay? So those are some types of things, the system assessments that you need to take a look at. You know, if there's something that happens, you know, like someone comes at change of shift, drives me crazy that they come at 6:20 to do admission, and then, you know, you can't always do that admission assessment that takes an hour or so before you get in there. Now, Six Sigma is something that you may have heard about. Probably Six Sigma is it's more used in business models versus in hospital systems. Typically in hospital systems we use Lean Six Sigma. But what you're going to see is that Six Sigma is a management system that uses quantitative data. Okay, what is quantitative data? Something that you can measure or count. Okay. Basically, again, it's a customer focus, very data driven. It basically focuses on the processes behind the system. Typically what you're going to see is there's much greater emphasis on the management, monitoring performance, and ensuring results versus the team members. Okay? One of the things with Six Sigma is that it's a boundaryless cooperation. Well, what does that mean? It means that everyone is involved, however, the chiefs are the ones that's most responsible. With Six Sigma, basically the aim is for perfection. However, they do tolerate failure. Though what you're going to see is that if there is a variance or a failure in the process, what they're going to do is examine that using that data and again revamp to try to aim for that perfection. Okay, it's again sort of a continuous quality improvement system. But Six Sigma, like I said, is more business model than hospital model. Lean Six Sigma focuses on improving process flow and eliminating waste. I know a lot of you, especially those of you that are at Northeast, you may hear they talk about lean huddle in the mornings prior to report. Okay? Basically what they're trying to do is to use that as a communication method for improving that process. Whereas what you see here is to make sure that people have had things communicated to them in a timely manner. Okay? Now, DMAIC, basically it's another process. Define the measures that will indicate success. Again, you have to set that standard. It's just like here, we have 80% as that competency level. That's our standard. Measure what the baseline performance can be, analyze results, improve performance, control, and sustain. These management systems, basically, guys, what I just want you to get out of this is that there has to be some method for improving quality of care. Now, the one that you're going to see most often are national initiatives. The National Quality Forum focuses on building consensus on performance goals and standards for measuring and reporting them. They are the ones that sort of set the national standards, what the national benchmarks are. Joint Commission has adopted national patient safety goals. And we'll talk a little bit more about those in just a minute. Basically, the National Institute of Healthcare has these goals. That there are no needless deaths, there's no needless pain and suffering, no helplessness in those served, no unwanted waiting, and no waste. Okay? Now, tell me about these goals. Are they measurable?
No.
What about no waste?
Zero. It's not measurable. What about?
No waste of what? You can make these measurable. Typically what you will find is that these national initiatives like this are usually very broad. And it's up to the institutions to make them very specific so that there's a way to measure them. Okay? Because they recognize that each institution is going to be different. These Institute of Healthcare goals apply to every healthcare setting. Long-term care, outpatient, inpatient, and acute care settings. What the goal of this might be in mental health may be entirely different than it is at the ER at Rowan Medical Center. So it's up to the individual institution to set the more specific goals. Now, Joint Commission mandatory patient safety goals. These are just a listing of them. I included a handout in your a handout that I want you to be familiar with these and how to implement them, but you don't need to memorize these goals. Okay? What I'd like to do is talk about them just a little bit. These are the Hospital Accreditation Program goals. There are different goals for mental health. There are different goals for long-term care. There are different goals for outpatient. But what I want to look at are the specific hospital goals. All right. Basically, the goal number 1 is improve the accuracy of patient identification. And what you're going to see is that, I always like, it sounds sort of like Star Trek, National Patient Safety Goal .01, .01, .01, you know, like Stardate, whatever. But what you're going to see is that use at least 2 patient identifiers when providing care, treatment, and services. What have we pounded into your heads from the day that Ms. Walker started talking to you about medications? Those 2 patient identifiers. All right? If you look, this is the rationale. Wrong patient errors occur in virtually all stages of diagnosis and treatment. We need to make sure that the person for whom the service or treatment is intended gets that treatment and not someone else. Acceptable identifiers may be the individual's name, an assigned identification number, telephone number, or other person-specific identifier. 2 patient identifiers when administering medications, blood or blood components, when collecting blood samples and other specimens. Patient's room number or physical location cannot be used as an identifier. In other words, what room number are you in? 309? is not an acceptable identifier. Basically, the other component of that is label containers for blood and other specimens in the presence of the patient. Why do we want to do that?
Make sure it's the right thing.
Make sure it's the right specimen that gets the label. Okay? Because I'm going to tell you, pee in a cup and pee in a cup looks pretty much the same. If it's clear yellow urine, okay? Blood in a pee cup and clear yellow, you might be able to tell the difference with. But if they're both clear, you don't know. So if your pregnancy test comes back for Mr. Smith as positive, you know that it's been mislabeled. Okay? What other things are we going to do to make sure that patient identification is done correctly? What do you always, always, always do whenever you're administering meds? Check their armband and their name, full name, date of birth. Okay? Actually, that's 3 patient identifiers, right? But that's okay. Better more than not. Now, my mother takes this a little further because right now, or at least used to be, there were 4 Marie S. Sinks in High Point. 3 of them go to the same doctor. 2 of them have the same birth date. So my mom goes every week, or every month, or every 2 weeks, or however often, to get her blood drawn to check her coumadin level. So when they come in and ask, what's your full name and date of birth, my mom says, you tell me. And then they will say, okay, this, and then she says, and my telephone number is, because not only do they go to the same doctor, they have the same name and birth date, but they both go to the Coumadin clinic. So she has to make sure that her 3.5 to 3.9 that her doctor wants her at is okay, and not the 2.5 to 3 that the other lady needs to be at. Okay? So it makes a difference. Okay. So, blood and blood components. Basically, we will be covering transfusions next semester, but just to let you know, it is a national patient safety goal that before initiating a blood or blood component transfusion, that you match the blood or blood component to the order. You take the blood and you look at the order. You match the patient to the blood or the blood component. You use a 2-person identification process with 1 person that has to be qualified to give that blood. Okay? When you look at this, it says 2-person verification process. The majority of your hospitals are going to limit that to 2 RNs. Okay? 2 RNs that are qualified to give blood will do transfusions. We'll check those. And usually what you're going to see is the process is a double verification. I may have the blood component with the paperwork for that component in my hands. My second RN is looking at the patient and doing that verification. And then we switch. I go and do patient verification, as they read the blood components out. Because the chance for error with blood component or blood component administration is very, very high. That's why students are not allowed to participate in blood administration beyond doing vital signs. Okay? But I'm going to tell you, once you get that RN behind your name, you're the expert. So, we'll teach you a little bit more about that. All right, goal 2. Report critical results of test and diagnostic procedures on a timely basis. You notice it says timely instead of 1 hour, 2 hour, 3 hour. Okay? What you're going to see is that your individual facility, your hospital, your clinic, wherever you work, will have a standard for what they consider timely. Basically, what would you want to do with a critical result? What are some critical results that you'd want to report? Potassium, either high or low. Sodium, either high or low. Lithium levels, or any drug therapeutic level. If it's within normal range, do I call the doc and say? All right. What other types of things would you want to result?
Coagulation factors. PT-INR.
PT-INR. Cardiac enzymes. What about white blood cell count?
Yeah.
Either very low or very high. Okay, those are types of things that you want to report. Let's go into the X-ray field. What X-rays might you want to report? A bleed in the head? Definitely. What about with lungs? Pneumothorax. Okay? Those types of things. How would you report those?
The doctor. Call the doctor.
You call
And right.
and write. What I would do is page the physician or call the physician, depending on whatever mode your hospital is doing. And the way that I would report it is this. There is a standard format called SBAR. Okay? Situation, background, B, situation, background, shoot, keep doing it in my head. A, assessment, and R, recommendations. Okay? Basically, I would say, this is Renee Hyde. I am reporting the results of patient Mr. So-and-so admitted for pneumonia. He has a serum sodium of 125. What recommendation would you like, or orders would you like at this time? And one of the things that's nice with these new electronic medical records is that I don't have to take a verbal order anymore. That physician can sit in their office and type in that order. Or they can pull up the result as well as the other lab work to take a look at it, and you can converse without having to talk about what the other lab results show. Okay? But using that SBAR system, situation, background, assessment, recommendation, those are the things that you want to do to make sure. Because think about all of you guys that have worked on IP. How many patients do you think Dr. Kelling has? Well, on that floor, but what about in Cabarrus County? Probably half of Cabarrus County goes to Dr. Kelling over at Family Medicine over there. So, and he's amazing, and he remembers most of them by face and name. But if you've got a physician that's covering anywhere from 300 to 400 patients in their practice, which most of these guys are, or healthcare providers are, then you have to make sure that they understand which patients you're talking about with which lab results. Okay? What about this one? Evaluate the timeliness for managing the critical results. Now, I am a nurse on the floor. Lab work has been ordered for my patient. They're a difficult stick. My techs have tried 3 times. I've tried. Can't get any blood. What would you do? Well, I'm sorry I can't get this lab because I can't get this stick. Do you just leave it at that? What would you do? Call the lab with one of their technicians or the IV team, depending on who does your difficult sticks. And if the IV team can't get it, call the doctor. So you need to make sure that that doesn't fall through the cracks, because the timeliness of the lab is very, very important as well, or the timeliness of the x-ray. All right. National Patient Safety Goal 3. Improve the safety of using medications. One of the standards here is label all medications, medication containers, and other solutions on and off the sterile field and perioperative and other procedural settings. Medication containers include syringes, medicine cups, and basins. Medications or other solutions in unlabeled containers are unidentifiable. Errors, sometimes trash, have resulted from medications not being labeled. Any of the surge techs in here? Okay. One of the things that you'll find is that anything that's placed on that sterile field, even if it's just sterile water, must be labeled. And this is something that we as nurses need to do. How many of you have given IV protonics? Did you label it? Mm-hmm. Even though you were taking it directly into the patient's room? Mm-hmm. You should. Because anything that does not come in the original container that is already labeled should be labeled. Okay? And these are the things that it should contain. The name, the strength, the diluent, any expiration date if not used within 24 hours. Most of the time we don't have to label a syringe with the expiration because we're going to use it immediately. Because I'm going to give you a clue, guys. Unless I pulled it up, I'm not giving it. Because you're not going to hand me a syringe and say, here, give this. Without me knowing, watching you do that. Okay? Date and time are not necessary for short procedures, but the hospital can require those. Alright? All medications, solution labels verbally and visually. Say, for example, in a code situation, we're giving epinephrine. The doctor may shout out the order, the medication nurse will pull up the epi, and what you're going to see is that the nurse that gives that epi is going to say epi 1 milligram in, and the person documents it. So you want to visually and verbally verify those things as well. If it's unlabeled, you throw it away. One of the things that you're going to see is you've got to remember, what are IV fluids? Salt water. Are they medications? Mm-hmm. Yes. So if those are unlabeled, you throw those away. Tubing. One of the things that you should always check when you go in your room. How is my tubing in date? If it's not labeled, you don't know. Unless that person just came up from the ER and you know that they just put that IV in. That way you can either have someone from the ER label it or you can label it yourself. But typically, change the tubing if it is not labeled. Alright. This is another one. Reduce the likelihood of patient harm associated with the use of anticoagulant therapy. Some of the evaluations. Only oral unit dose products, pre-filled syringes, pre-mixed infusion bags when these types of products are available. That's why whenever you give a Rextra or Lovenox, it's in that pre-filled syringe so that you don't have to draw it up. Whenever you are doing a heparin drip, it comes up from the pharmacy. Okay, because what happens is that the increased risk of medication error occurs whenever I put the heparin in the bag and then something else happens and we need another bag and then someone else does it because the chance of error increases. Pharmacy is the best person to go ahead and mix those bags. Now, that doesn't mean that in an emergency situation that can't be done. But remember, that's a variance and it needs to be documented as such. Any of you, when you watched a discharge or admission, talked about reconciling meds or reconciliation of medications? What did they do?
Two nurses, well, they check the orders and then two nurses check after each other. They're all reconciled.
Okay. When do you do medication reconciliation? I just told you admission and discharge. When else would you do it?
Going to a different floor.
Going to a different floor, a transfer. When else?
You're adding or taking away.
When you're adding or taking away. The other thing is that if they go to the OR or to the ICU, each time you change level of care, there has to be a medication reconciliation. And that's to verify that the medications that they were on previously have been looked at to make sure that they continue on those medications or there's a specific reason that they don't. One of the things that gets missed quite a bit, I'm going to tell you, whenever you have patients going to the OR and coming back, are eye drops. Like glaucoma drops. Alright? And those are very important because you go 2 to 3 days without those drops, it can result in blindness for some of these patients that are extreme sensitive to not having those medications. So one of the things you're going to want to look at is to make sure that all of their meds are either on that list or there's a specific reason why the physician did not continue with it. Improve the safety of clinical alarms. This is a new one, but it is one that Joint Commission is very, very focused on right now. What are some of the clinical alarms that we see in our practice?
Bed alarm, chair alarm, call bell.
Call bells.
Bed alarm, chair alarm.
Bed alarms, chair alarms.
IV pumps.
IV pumps.
Continuous pulse ox.
Parameters on your tellies.
Continuous pulse ox. Well,
Continuous pulse ox. Those of you that are at Northeast and they've got that throat thing, where they will do a continuous pulse ox, it would drive me absolutely crazy. And they've got this piece of tape they paste on their throat, and it does a pulse ox and breathing and all sorts of things. But one of the things that you're seeing, and it's not only in ICUs, is something called alarm fatigue. Okay? It's just like going into Walmart or Kmart or Belk's, and they pipe in that music that's just irritating, because do not do instrumental versions, soft versions of the Beatles or AC/DC. I'm sorry, you don't do that. But after a while, people that are working there no longer hear it, because it is no longer a new stimulus. And that's what we do to our environments, is that after a while, those types of things no longer register. Okay? What do we do sometimes when the IV pump alarm goes off? Silence it. What do the patients or families do sometimes? Okay? Why is that thing alarming? Something is wrong, and you need to check it out. The other thing is that I've seen people turn the alarms down so it's not loud. What is that doing again? It puts that patient in jeopardy, because that you no longer can hear the alarm from the outside of the room. Give you an example. There was a recent hospital, so it may have been in one of your books, but what they had done is they had decentralized their cardiac tele, where that the tele monitors and the alarms were now in the nursing station. And what would happen was that if the nurse was in the nursing station, they could see what the alarms were or see what the rhythms were. Okay? But if one of the nurses was not in the nursing station, it fell on the unit secretary to get someone if that alarm went off. Well, if the unit secretary was not in the unit, who was monitoring those alarms? Nobody. Well, what happened was that the unit secretary told a nurse that Mr. So-and-so's alarm's going off. And the nurse said, okay, I'll check it. But unfortunately, what happened is that on the way down to check that patient, she got called into something else. And the patient didn't get checked. Well, the unit secretary had been told, and then a lot of nurses have been doing this, that these stupid alarms, they're so sensitive that whenever the patient turns over in bed, they go off. So the next time the alarm continued to sound, she thought the nurse had gone to check on the patient, so she hit the silence button. And that happened 3 more times. The patient was in B-fib and died. So now this hospital does not do the monitoring at the nursing station. You can have a readout, but there is a centralized monitoring station where there is a call that says you need to check Mr. So-and-so now, instead of hitting that button. Okay? One of the things I'm going to tell you guys is that the only reason that you turn off an alarm is that you're in that room and you are working with that patient to fix the problem with that alarm. Immediately, when that problem is resolved, that alarm goes back on before you leave that patient's bedside. Make sure that those alarms do not get cut off. And you focus on joint condition. And it should be for everyone. Reduce the risk of healthcare associated infections. Boy, that one's in the news right now, isn't it? I think there's a second staff member that has been confirmed. So, I'm not going to go over that one because I think we all know infection control. However, we might need to review a little bit more. I heard on the news last night, Devon has, at least Devon, Maine, has set up a unit to deal with
Forsyth and Prince Williams.
closed down equipment to hospital identifies safety risks inherent in the patient population. Basically, those are going to be like your suicide patients that are at risk for suicide and mental health, or any other patient that comes into the hospital, whether they be in mental health or acute care. The risk for falls is also within that protocol. Introduction to the universal protocol for preventing wrong site, wrong procedure. This is also a biggie. I mean, one of the things that you will see is that still at least 5 or 6 times a year the wrong surgical site gets operated on. Where it's a knee replacement and they replace the wrong knee, or they amputate the wrong leg. It does make a serious difference. When I had my eye surgery, my doctor, whenever he came in to do the pre-op thing, forgot to mark the surgical site. And so they stopped that procedure and made him come. He had already scrubbed and gone into the OR to wait. And they made him come out, mark the surgical site, and then scrub again. And I could tell he was PO'd because I had this X that was on my entire side of my forehead for my cataract surgery that took me almost 3 days to get it off because I think he used Sharpie. I mean, seriously. But it didn't matter to me because I was having the other one done in 2 weeks anyway. But it would have made a difference if they were going to do an amputation on my leg and they marked or misidentified the leg. Okay? That's one of the things that when you went to the OR, did you get to see them do the check-in? Okay. Which leg are they operating on today? And they would not prompt them, the right or the left. Okay, what you have to be very careful about, the left leg, and the patient says right. They're operating on the left leg. Is that correct? Yes. Okay, because if they keep saying right, that's right, that's right, you know, you got to wonder, is it the left or the right? So you got to make sure. Okay? So let's go ahead and finish these and then we'll take another break. Wrong side, we talked about timeouts. Alright, timeouts are one of those things that you do before procedures of any sort. You will see them done not only for ORs, but you will see them be done for like any invasive procedure, like a PICC insertion or a chest tube insertion. Anything that is an invasive procedure. Those of you that watch circumcisions this summer, they did a time out before they did that circumcision. make sure that it was the right patient. Though sometimes when they had those poor little boys lined up in a row, it didn't make that much of a difference, but it would make a difference if that mom decided that that's not something she wanted to done, or the dad. Okay, so let's take a break. But it is one of the most important things that we as nurses are starting to do. Basically, what the aim of it is to provide the best possible care based on the best available research. Institute of Medicine has issued a couple of reports, starting with that one to err is human. And now what they're trying to do is to deliver strategies to improve healthcare system. Now, Sigma Theta Tau is the National Nursing Honor Society. And what Sigma Theta Tau does is that it is the vehicle for disseminating a lot of the nursing research out there. Their magazine, as well as their conferences and things like that, disseminate a lot of the nursing research. Some of the barriers for evidence-based practice, probably the number one is lack of time, lack of knowledge, negative attitudes, lack of institutional support. And right now, there's a limited amount of research findings that are applicable to nursing. There is a big, big move right now in medicine that all of their interventions need to be evidence-based. And that one of the things that you will find is that that's one of the ways that nursing is moving as well. Even though you may hear it referred to as evidence-based medicine, evidence-based occupational therapy, evidence-based nursing, think of it more as evidence-based practice, okay? Because what we want to do is care for these patients the best way possible. It's just like dear old Flo. Not Aunt Flo, but Florence. Okay? Basically, she was one of the first people to use evidence-based practice back in the Crimean War. Basically, fresh air and washing hands. One of the ways that you saw that the amount of childbirth deaths definitely decreased was that someone discovered that when you did not wash your hands or change your clothes between going from this woman with this rip-roaring, raging puerperal infection to delivering this new baby, that whatever infection this woman had, now this woman will get. That was the beginning of evidence-based medical practice. So one of the things we are starting to see more and more is, why do we do the things that we do? Well, one of the reasons that you always hear is, we have always done it this way. Did Miss Beaver tell you the roast story when she talked about evidence-based practice? Basically, what happens is that this woman was going to roast a round of beef. So what she does is she takes it out of the grocery sack and then she cuts it in half and puts it in her pan and freezes the other half and puts it in the oven and cooks it. And the family says, well, this is wonderful. How did you do this? And why did you do it this way? Well, that's the way Mother always did it. Well, why did you cut it in half? Well, I don't know. That's the way Mom always did it. So she calls her mom and says, Mom, when you buy a roast, why do you always cut it in half?
She says, well, the only pan that I've got will only take half a roast. So I just only did half of it. So it's sort of like that. You've got to figure out, why did we do those things the way that we've done it? Why do we always do vital signs at the times that we do them? Is it sufficient to do Q8-hour vital signs? Or are Q4-hour vital signs better? Or Q2 vital signs? What's the reason that we do those? Other than just give me something to do, or give the nursing assistant something to do. It's not that we justify their job by giving them the vital signs to do. There's a reason behind that. One of the things that you're going to start seeing is that evidence-based practice, nursing practice, is a lot more clinical guidelines. Okay? Clinical guidelines are one of the ways that we can establish better care for our patients. And if you look, hang on one second. If you look at this, those clinical practice guidelines typically are based on, if this is not in your handout, but it's in the book, basically what you're going to see is that clinical practice guidelines are level 1, meaning that they have been developed using systematic reviews and large multi-center trials. And typically those practice guidelines are national standards. And a lot of nursing organizations, the OR nurses, AWAN, the Women in Neonatal Nursing Organization, AANN, the Neuroscience Nurses Association, all of those people are printing practice guidelines to focus and to guide the care of those particular patient populations. So when you're looking at practice guidelines, that's probably one of the highest levels of research that you can get. They're national standards developed with large multi-system clinical trials. Now, one of the things that you'll find whenever you're looking at research data is that it depends on where you are as to how much information you think that there needs to be and how reliable it's going to be. For example, if you're looking at your studies, is it just a single experimental study? Or is it non-experimental? Or is it case reports? What are case reports? What does that really mean? A case report would be what? Just a situation. You ever had patients say that I've been written up in the medical journals? Okay? It's an unusual case that may have happened with one person or a couple of people. Okay? It's not something that happens very frequently. But look where it is. It's very low on the list. It's just like someone saying, well, don't shop at Walmart because their prices are not the lowest. But that's because that may have been their experience on that one particular item on that one particular day. Okay? So the higher that you get, the more reliable that research is going to be. Okay? So this last level here That's like expert opinion. This is like Sanjay Gupta on CNN, or this is, what is that, the guy that, the white-haired guy on LaPook. Yeah, that's his name. Dr. LaPook on one of the evening newses. They always have these experts to give their opinion. Okay, and you know what they say about opinions? Okay? Yeah, it may be a doctor, he may be an expert, but it's not as reliable as some of these other studies. Okay? So think about that when you're thinking about research. Basically, remember that scientific research is the most objective and the most reliable source. And with evidence-based practice, that's one of the things that you're going to see. There are lots of ways that we go about that, but most people use the PICO formula, patient or patient group. Okay? Basically what you want to do is come up with a question. And what is this burning question that I have to know? What is the intervention of interest? And then I want to do a comparison. Do I compare that intervention with what we're currently doing? And then what's the outcome? For example, toilet paper. Do you put the toilet paper on the roll so that it comes off the top? Or do you put it off so that it comes off the bottom? Everybody has a different way of doing it. And it drives me absolutely crazy. In fact, in the hotel, I changed the toilet paper because it drove me crazy. The intervention might be, do you pull it off the top, do you pull it off the bottom, and then you compare. Is it more personal preference? Or whenever you pull it off the bottom, do you only get 3 sheets and have to dig and find it again, and you do this and do this and do this? What's the outcome? The outcome is that I'm so OCD, I changed it in the hotel because I didn't like it that way. Okay, so you've got to come up with a way that you figure out what this intervention is going to be. It also is, if you have cats, you learn to do it this way, especially whenever they do this, because they'll shred the toilet paper if you do it the other way. Find and review evidence. Basically, these are a couple of agencies that are good sources for looking at the literature. I'm going to do this one more slide and then I'm going to let you go eat. We want to formulate that clinical question. Judge what the quality of evidence. Is it that expert opinion, or is it multi-level studies? More than one study that came out with the same evidence. We want to share that information. Dissemination can be done in a variety of ways. You can do a presentation for your staff. You can write an article for one of the nursing magazines. You can present it in class, just like you guys did with your community resources. Or like I experienced this past weekend at a community college conference where several people disseminated their research findings from their PhD and listened to those. Got a few good ideas. But disseminating that result, if you don't disseminate it or let someone else know about it, did it do any good to do that research? No. Okay? All right. We will start with